societies. I was going to say the Nigerian Cancer Society, the National Cancer Society of the African countries. Academia play a very important part because most of these changes are best driven by research, which comes out of the academic community. Media are also important in sending the word around and also making that advocacy. The first ladies of national and subnational governments play a role because they have a platform as the chief advocates of their region. They're able to engage in high level advocacy that is required to bring about these changes. And it is the hope that in the case of the African Union, the actions that we carry out, the changes that we spoke about, can be targeted to constitute regional childhood cancer advocacy groups, lobby the health ministers from 3 reference countries to champion a regional childhood cancer action plan on particularly in the Committee on Health, Population and Drug Control. And then we can also hope to secure operational funding for the sub-regional health organizations so that they can conduct assessments. For the national level, the national cancer societies can develop a childhood cancer advocacy strategy and disseminate advocacy priorities with influential voices, again in the academia, media, and other allied civil society groups, and also coordinate a national childhood cancer awareness campaign to create that needed awareness and also demand action from the ministries of health. A very good example that I can share is the experience in the Medicaid Cancer Foundation, where we were able to successfully engage the National Health Insurance Scheme in Nigeria on including cancer care as one of in the healthcare packages of the scheme. We were able to successfully engage the head, who was an ally in that he was interested and was not a blocker, like I mentioned in the beginning. And so we identified him as an ally because he had a personal interest in cancer. And we're able to ensure that some of the needed care that cancer patients need, the treatments, the diagnosis, were all covered, as well as screening. And it continues to increase and improve. Just at the end of last year, we're able to add some more medication to chemotherapy to the list of the drugs that are provided by the NHIS in Nigeria. So in conclusion, it's relevant that we continue to engage and leverage the opportunities that the African Union presents and realize the importance of the regional body as well as our state ministries of health through the various mechanisms and people that I have mentioned. We have seen how the global COVID response has gone, and it showed us how relevant political will and strength putting together those allies can be. In a very short time, we were able to overcome the COVID pandemic. We're still in it, but it's ongoing, and a lot of the efforts that were put into it could only have happened if there was a global cooperation. And so if we put the same will into cancer care, we will be able to see some difference. That type of strong and sustainable collaboration can be increased across different sectors and actually work with the WHO Childhood Cancer Initiative so that they can filter down to the country level. CSO engagement I have spoken about is very important, and there's a need to realize that this engagement is different, and that's why the topic talks about the African Union and then the health ministries. It's the way in which we engage the global, the regional, and state organizations are very different, and we must have work plans that stick to this and speak to that aim. The AU declaration, for instance, at this point, I wanted to talk about the recently launched Ray of Hope initiative by the IAEA. At this point, I wanted to mention the Ray of Hope initiative that was launched by the IAEA and presented to the African Union just recently at the last meeting that they had of all the heads of states. Now, the African Union presents a platform for planned and sustained donor support. And if this initiative is thought through properly and followed through, as we saw the heads of state declare, the president of Senegal, we will definitely be able to see a concrete change and measurable change in cancer on the continent in a short while, as long as the political will and the leaders of the country agree to that. However, it's important to note that declarations are often made, but if we do not see them through with the required advocacy from the different groups that we mentioned, they can sometimes not be as efficient. The Abuja Declaration of 2001 is a case in point where all the heads of states of Africa came together to agree to spend 15%, to allocate 15% of the national budget on health. As of today, only two countries have been able to meet that goal, Rwanda and South Africa. The rest, some of them are improving and trying to reach it, but it constantly falls below the 15%. But it's not all bad news. After that declaration, the individual amount spent per capita, per head on health in Africa, or the amount of coming from donor agencies to an individual person tripled, it more than tripled. And so, although it is a bit lopsided, and which is why we need bodies like the AU to ensure that the distribution of any support is more evenly spread, it's in a sustained and organized way. So such initiatives are important, and we must continue to encourage them as well as utilize them. That is why the advocates are there. You need to learn about these things. You need to read about them and use them in your work plans to have effective change. Thank you for listening, and I hope that you will enjoy the rest of the Congress and look forward to speaking to you physically in future.
So thank you very much to Her Excellency Zainab Shinkafi Bagudu from Nigeria. I think we've just heard a masterclass in, how to actually highlight the challenges, but how to implement solutions, how to get those relationships, both at a continental level, but also nationally with your governments. There was so much content in that talk that I hope you will all take advantage of the conference app, sort of live broadcasting that will allow you to replay that, because I think a lot of information there useful to you to digest and to take home. Now, I believe Sharon from the WHO Afro region has arrived in the room. So I'd like to invite her to come up to give her talk, if she's here. I thought I just saw her. She is here. Are you ready, Sharon? Please come. And so thank you very much. Now, it's Sharon Kampabwe, is that correct? Please come up the steps. So Sharon is the WHO Afro regional representative and is here speaking on behalf of Andre Ilbawi, Cancer Technical Officer for the WHO, overall cancer and specifically the Global Initiative for Childhood Cancer. Do you wish to speak at the main microphone? Yes. Okay. That's perfect.
Thank you. I think I can have my slide. No, they are. Good morning, everyone. My name is Dr. Sharon Kapambwe. I am the WHO Technical Officer for Cancer, responsible for supporting the East, I think I can take it off, responsible for supporting the East and Southern Africa, and particularly supporting initiatives that the WHO has, and one of those initiatives is childhood cancer. So I'm also making a presentation on behalf of my colleague who couldn't be here, Dr. Dili, who is supporting West Africa. So today I'll talk about increasing access, advancing quality, and saving lives, the WHO Global Initiative for Childhood Cancer. The outline of my presentation this morning, I will talk about the context of the initiative, approach to implementation, and how we are engaging the countries. So we all know that mortality from childhood cancer reflects global disparities in health outcomes. We are well aware that 80% of children with cancer will survive in high-income countries, and only about 20% of children will survive in low to middle income countries. And for Africa, a study done actually showed that survival is about 11.6%. But we know very well that close to 90% of the world's children live in low to middle income countries. So this disparity of 80% surviving in high income countries and only about even less for our region of children surviving with childhood cancer is one of the greatest health inequities that we have currently. And we also know that if we look at some of the avoidable deaths from childhood cancers, and some of you seated here will be well aware of this, we know that in the low middle income country, these basically result from lack of diagnosis. We have insufficient diagnostic services. So some of the children actually go without being diagnosed. And you can see from, and I'll be able to point that, we can see from the table on the right, my right, that should be your left. You can see from the table on the right, which is kind of giving the schema over how the colors are. You see lack of diagnosis, and you look at low to middle income, you see that from about 60% to about 100%, which is going to give you about 40% of the children are going without a diagnosis. We have issue of misdiagnosis or delayed diagnosis. Most of the children, the index of suspicion in our clinics or in our health facilities is very low. Most of the children who have childhood cancer because of the presentation are going out as malaria, they're going away as tuberculosis, and yet these children are actually having cancer. So we have issues of misdiagnosis. And those where we actually try to make a diagnosis to really get a confirmation will be delayed. We have obstacles to accessing care, one of which is really drugs. Access to childhood cancer medicine is very difficult. strengthened. So in a way, we have talked to this, and I don't want to talk a lot about it, but we need to define needs in for the country. We need to ensure that stakeholders are convened. That's a starting point. All the stakeholders, we need to know who is working where. On the country level, that has to be done. Have your national stakeholders, which prioritize how you're going to move. That when we come back to SIOP 2025 and 2030, it will be about reporting what we have done. I'm not coming back again to talk about the same things that we've talked about today, and we hope that we will generate investment cases. And like I have said, we've got regional actions. We've got the GICC partners that are there. We've got the World WHO. We've got IAEA. We've got GFAOP, ICPP. And if any of the partners is forgotten, I apologize in advance. We've got SIOP, Childhood Cancer International, World Child Cancer, and of course the WHO. So it's not just WHO working its own, but we have come together to work as partners to ensure that this is implemented, and all these regional networks are taking place. I come down to Africa quickly. So these are the countries that we've engaged. When we talk about a focus country, it's a country which has a formal participation in GICC that we have received from government a request to be part of GICC. It's not just a request, we also have a criteria that we're looking at. Is there a focal point at the Ministry of Health who's handling childhood cancer issues? Do we have at the Ministry of Health level plans, policies that are supporting childhood cancer? Do we have a way of monitoring what is going on? Do you have childhood cancer medicines on the essential medicines list? They are things that we're going to look, how is the governance structure? So sending a request is fine, but we also have a criteria to ensure that the countries that are being adopted as formal GICC partners have what is required to be. So currently we have Ghana, Zambia, and Senegal. And we have countries in initial phases, countries which are working at identifiable cure-all projects. There's something they're doing in the cure-all. So that is where we have Zimbabwe, South Africa, Uganda that is hosting us today, Cameroon, we have Mali, and then we have countries with ongoing dialogues. So we have Mozambique, we have Ethiopia, Burundi, Tanzania, Kenya. So there are countries in dialogue, there are countries in initial phases, and we have focus countries. Remember, Africa has 47 member states. Having 3 focus countries is truly an underrepresentation, and we hope that governments that you are representing here will be able to work through that we get more and more partners coming in as focus countries. But that does not mean that the only people who get support through GICC are only the ones that are focus countries. We can support some level of cure-all projects that are going on in these countries. And this is just a way of some of the priorities that countries put in, and you see Afro is in one. So we were looking at issues of cancer control planning, we're looking at issues of essential medicines as being key, defining standard guidelines. Most of the countries have come back and said we don't even have guidelines for guidance, for treatment, for early diagnosis, for childhood cancer. And they were looking at that. So that is one of the priorities that we feel that we should go in for the countries. The other thing I want to mention is that, as I wind up, is that in December 2021, further to the GICC, WHO in collaboration with St. Jude, with an investment of 200 million, launched the platform for global access to childhood cancer medicines. And this is because afterwards we found that access to medicines, childhood cancer medicines in particular, is a huge hurdle for us to achieve survival, the 60% survival rate that we're talking about. Because we have supply side barriers, we have demand side barriers. You know, most of the supply is you have a weak business case for childhood cancers. It's a small population, so probably pharmaceuticals thinking, no, this is small. it's a small market for us. Limited manufacturers as well, and verifiable quality. You're not sure of what you're getting in the era of falsified medicines as well. And we have demand side, inadequate financing in the public sector for childhood cancers, and no government tender processes or weak infrastructure for focusing of these drugs. So we thought this is one area that we should really concentrate on. So those are the challenges to access to medicines in childhood cancer. Because of these supply and demand barriers, you find that countries in low middle income countries pay a higher price for these drugs, up to 7 times. And then you find that over 50% of the countries from the studies we've done in low to middle income countries report unavailable medication or interruptions. And you know that that will lead to low childhood survival rate. And then medicines as well. I've talked about substandard and falsified medicines as well. So this is the global platform for childhood cancer medicines access, which its goal is universal, sustained access to quality assured, essential cancer medicines for all children in low to middle income countries. The outcomes we're hoping for is to have affordable medicines, no out-of-pocket expenditure, availability, no interruptions, accessibility, that we're looking at no treatment abandonment by children, and that care is close to the home, quality assured, that we have medicines that are not substandard or falsified products. The objectives is to do market shaping to promote access and innovation, and also at the end of the day, strengthen the health systems. So we're looking at addressing community priorities, that 85% of the countries that will be involved in the WHO GICC for childhood cancers, requesting additional support for medicines, and that 70% of the countries, the stakeholders, will look into this as a priority. In conclusion, so as we talk about the platform will not be restricted to focus countries, but the platform will be, and we can talk about phases much later. I think I've chewed most of the time. And in conclusion, we must remember that childhood cancer is an emerging public health problem, which progress must be accelerated through the Global Initiative for Childhood Cancer. We must remember that investing in childhood cancer as part of universal health coverage offers health systems an opportunity to strengthen the NCD agenda, and that success of this, if it's achieved, because of passion, because of collaboration, commitment, we will see that we're improving the cancer care for those children, and policies will grow in our countries. By implementing the Cure All, we're also going to see that support of the WHO on 3 levels and all the stakeholders is going to be across all sectors, and it will contribute to the inequality gap that I talked about. And at the end of the day, that we are going to indeed add to serving an additional 1 million in the next decade. With that said, I'll sincerely like to thank you for this opportunity. And Kathy, I apologize for taking up too much time. And we have contact information for the WHO, which will tell you more about this initiative. And also, I think at the beginning, we had our emails. I'm available here throughout for the countries that want to engage and learn more. And of course, we've got the partners, and we look forward to having the questions. And I'm sure I have Dr. Nikhil Bhakhtar in the audience as well, who will be able to answer some of the questions, has been with us from the very beginning. Thank you so much for giving us this time to share this platform.
So thank you very much, Sharon, for speaking on behalf of WHO in Africa. And Sharon, Dr. Sharon Kapambwe, is a key contact person for you all. What I would like to ask is if the speakers could, once they finish speaking, come and sit at the top table, as I'm sure there will be people wishing to ask questions at the end, and I'd like to ensure we do have a bit of time for discussion. So thank you, Sharon. Fantastic overview. The next two talks are going to be from senior pediatric oncology leaders in two countries that are making great progress in improving their childhood cancer services. The first is a video recording by Professor Lorna Renner from Korle-Bu Teaching Hospital in Accra, Ghana. She very much wanted to be here today, but there was faculty business that was clashing, and so she'd been unable to travel. So I don't know, are you ready to play Professor Renner's video? Yes, please go ahead.
I'm going to present on the GIC's implementation in Ghana, progress, challenges, and recommendations. Wanted to stop, then I'll start again. I just wanted to stop recording. Is it recording? Yes, it's. I can start again.
Could you perhaps fast forward the video to the point at which she starts speaking?
Hello. I'm going to talk about the GIC. As a background, Ghana has a population of over 30 million, with 40% under 15 years of age. And pediatric oncology was started in Ghana with the Breakfast Tumor Project in 1968. Currently, we have two comprehensive pediatric oncology units in Accra and Kumasi, and a third unit, which was just set up about 2 years ago at the Greater Accra Regional Hospital. In addition, we have 4 shared care centers, and these are all shown on the map, from the north parts of Ghana to the southern part of Ghana. Ghana has been involved with the GICC since the World Health Assembly in May 2015. We were co-sponsors together with the Russian Federation, the Federal Republic of Germany, and the Philippines. And as a result of this side meeting, we called on the 68th World Health Assembly to address the human rights and needs of children with cancer, survivors and their families, and to recognize the fight against childhood cancer as a top global health priority. This is the GICC, which has the aim, as we all know, of achieving at least 60% survival rate for childhood cancer globally and reduce suffering for all. And the strategies include developing centers of excellence for access to quality care and universal health coverage through to standardized regimens and advocacy, and linking policies and governments, integrating childhood cancer needs. What has been the progress so far? Ghana held its first stakeholder meeting in November 2019, and you can see the stakeholder meeting with representation from WHO, SIOP, World Child Cancer, our Ministry of Health, National Health Insurance Authority, academia, and the pediatric oncology units. Subsequent to this, various actions have been undertaken, and there was initially a situational analysis of childhood cancer services in Ghana to determine the gaps, And subsequent to this, we've also developed a National Childhood Cancer Strategy document, which is quite comprehensive. And the Childhood Cancer Society of Ghana has been formed, and we're in the final phases of developing the National Childhood Treatment Guidelines. We've started trainings down to community level in various aspects of childhood cancer management. The vision that's been incorporated in the National Childhood Cancer Strategy is quality care for cure for all children affected by cancer in Ghana, with the goal in line with the GICC goal of at least 60% cure rates by 2030, and to ensure at least 80% of all childhood cancers in Ghana have access to care by 2030. With objectives including strengthening governance for childhood cancer, awareness creation, building capacity for cure, promoting research, and cancer registries. The Childhood Cancer Society of Ghana was inaugurated in September 2021, and one of our first missions was to develop national protocols and guidelines. These were based on well-known SIOP PODC guidelines. SIOP is national guidelines, and other guidelines, including COG guidelines. And the protocols looked at treatment for leukemias, lymphomas, the commonest cancers, retinoblastomas, worms, etc., all the way down to hepatoblastoma and some selected brain tumors. Currently, the guidelines are undergoing review, and we hope to have some input from ARIA resources. The guidelines also included care with regards to palliative care and supportive care, which was quite comprehensive, but was simplified on the basis of the WHO IMCI for use in communities down to healthcare center level. The guidelines also included referral pathways incorporating early warning signs for early detection to promote early referral to the appropriate facilities. Building capacity is key, so we've started training pediatric oncology fellows, Ghana College of Physicians and Surgeons, and Kolebu Teaching Hospital. We've had 13 trainees since 2018. We got our first graduate last year, and we're expecting 3 graduates this year. And we have 1 each trainee from Sierra Leone, Liberia, Nigeria, and Cameroon. Fortunately, we have support with WCC support from UBS funds. There's also a training program for pediatric oncology nurses. 18 graduated last year, and 12 are currently in training with the Ghana College of Nurses and Midwives. We are also training pediatric oncology pharmacists, and pathologists have benefited from a Sanofi Foundation grant where they're improving on pediatric oncology pathological diagnosis, and this will be spread across the sub-region so that other pathologists will be able to benefit from the training program. Hematologists have not been left behind, and we now have some flow cytometry support from World Child Cancer. When it comes down to the national and further down to the district levels, we're engaged in early warning signs and symptoms trainings, and this has been accomplished in almost all of the 16 regions of Ghana, and is ongoing. And it's programmed together with World Child Cancer and the Ghana Health Service, and it's also been linked with the National Retinoblastoma Program. We are disseminating supportive care and palliative care training in regional, district, and at community level, and this is also being undertaken by Ghana Health Service with WHO support. With regards to registries, there's a limited population-based registry in the middle belt of Ghana, that is at Kumasi, and this includes the pediatric oncology unit at the Komfo-Anokye Teaching Hospital, and it's part of the UICC City Cancer Project. Fortunately, good news for Ghana is the universal health coverage. The 4 commonest childhood cancers are being integrated into the National Health Insurance Scheme benefits package. We should have started in January, but they're still working on modalities for incorporation. And this will include the treatment for acute lymphoblastic leukemia, Burkitt lymphoma, worms, and retinoblastoma. We receive other financing and support internationally from World Child Cancer, so that most children with, who are admitted to our units will be able to receive funds for diagnosis and treatment. And we also have a lot of support from local donors. We've had a hostel constructed by the First Lady of Ghana in Accra, which can accommodate up to 30 families of children undergoing treatment for cancer. What are our challenges? The usual challenges of late diagnosis, sometimes treatment abandonment, and deaths as a result of most often, disease progression, as a lot of our children present with advanced disease, occasionally relapse, and occasionally from drug toxicities. We have problems with the health system, still limited access to care, late referrals, and limited geographical access to the treatment centers, and human and technological resource capacity limitations, so that we're not able to undertake the diagnostics as quickly as we should be. And also sometimes there are limitations with the multidisciplinary management of the cancers. Drugs is sometimes an issue because we are not able to ensure that the drugs are of good quality. And sometimes we have problems with supportive care, including blood and blood products and palliative care drugs. And costs are still prohibitive for parents. There's a limited cancer registry, as was mentioned earlier on in Kumasi, but we need to make sure and spread it so it becomes a national registry. And we still need more political commitment so that the childhood cancer strategy will be implemented and will not be a strategy just on paper. What have been some of our good practices? And from this, I can come up with recommendations. Local ownership is key. And right from the onset, there's been local ownership. They've been involved from hospital up to national governmental level, involving our stakeholders. And then the priorities and activities should be determined, and they have been determined in Ghana by our local needs. We have a local steering committee oversight, and it's important also to have a local champion. With regards to childhood cancer strategies, it's important that the reach goes down from national to community levels when it comes to awareness and aspects of care, which should be based on available resources at each level. Having a multidisciplinary team is important, thinking about that so that there's holistic management of children with cancer when it comes to capacity building, so that we have good human and technological capacity and good policies in place. Strategic partnerships have been extremely beneficial, and that's a recommendation for everyone. Both local partnerships and international partnerships. We've been fortunate to have World Child Cancer. We've got a lot of partners locally as well. And we do need to increase advocacy for more political commitment so that we can implement the childhood cancer strategy so as to increase access to care and improve outcomes on the road to achieving 60% survival by 2030. But important for this, for monitoring and evaluation, is to have a working cancer registration, a national type of cancer registry. So what can we offer children with cancer in Ghana? I hope a brighter future. Now I'd like to say thank you to SIOP, World Child Cancer, the staff and pediatric oncology patients in Ghana, and to all of you for your attention. Thank you very much.
So thank you very much to Professor Lorna Renner for that nice overview. And I think, giving you some practical examples of what they're actually doing in Ghana, please do reach out to Lorna, and some of the Ghana team are here. I know Victoria Paintsall is here, and Nihad. So there'll be people you could talk to if you wanted more details. Now I'd like to invite up to the stage Professor Leila Hessisen. She is Professor of Pediatrics in the Medical School at Rabat. Leila is the immediate past president of SIOP Africa and has been doing a tremendous job in both building leadership capacity more generally and then very specifically the global initiative implementation in Morocco. So Leila, over to you.
Thank you very much, Katie. It's a dream becoming a reality. We have been waiting for this event for 2 years. Thank you very much, Joyce, and for the local organizing committee. I know that this is a challenging. So I'm here today to present about the implementation of GICC in Morocco, knowing that for the WHO we are considered as part of the IMRO region, but it's not a problem because we consider that we are African before all. So about Morocco. So Morocco is a North African country. We are between the Mediterranean Sea and Mauritania. We have 37 million population, and we are a middle income country. So this is the history of the development of pediatric oncology in Morocco. We initiate in 1920. Those were only some beds in pediatric facilities where some doctor motivated initiated to treat some patient. Then at the same time they decided that they need NGOs to help them, parent support group. So at the same time, in 1980, the two pediatric oncology units was developed in Rabat and Casablanca, and at the same time, each one was supported by a parent group. In 1996, we created our national society, and this was because we were hosting a SIOP Africa meeting. In 2000, we joined the GEFOP, and we were founder of this group. And the landscape of pediatric oncology in Morocco changed when was created our Princess Foundation for cancer prevention and treatment. In 2010, we had our first cancer plan, but it was for adults and children. It was not specific for children. And at the same time, 3 other units appeared, new units. And in 2015, we had our own training program accredited by the University of Rabat and the University of Paris. And finally, in 2019, we have been selected as implementation site for the GICC. So what is the burden of the childhood cancer in Morocco? We don't have exact or accurate data because we don't have a pediatric cancer registry. We have national, regional cancer registries. This gives us approximate information about the number of patients. So we estimate that we have between 102,000 and 105,000 new cases per year. Most of them are acute lymphoblastic leukemia. So the implementation of GICC, the process initiated in 2019, we have been contacted by colleagues asking us to send urgently a letter of intention through our Ministry of Health to the WHO, and this has been done like in 2-3 days because a week after the ministry changed and we had a new one, and we had this chance to send our application. The partners are the Ministry of Health, WHO, our Princess Foundation, and the National Society. So we began our process. First step was to set up a national steering committee to guide us through this process, and we began updating data about what was the current situation in Morocco. But at this step, we had an information that was lacking, so we had to stop this process and to find a solution. So what is the missing data? I will speak about it after. So within the process of update, we did a SWOT analysis, and this shows that we had to take advantage of 40 years experience in pediatric oncology. We had strong networks. We were 6 pediatric oncology units working together, coordinating, discussing difficult situations, and using the same protocols, adapted international protocol, adapted national protocols, and international. We had our own training program, and we had a strong support from NGOs, but we had also weaknesses. One of them is that we don't have childhood cancer plan. There is a problem in referral, which leads to delay in referring patients. So advanced stage when we receive it, we have suboptimal access to drug with shortage. We had also suboptimal access to accurate analysis for diagnosis, and we have not center of excellence for subspecialties like pediatric neurosurgery, orthopedics for bone tumors. So those are some of the weaknesses that has been identified. And as I told you, we have a strong and well-organized network of NGOs collaborating and supporting us. So at this step, what was the missing data? So those who have seen the last movie of Batman can understand what's important is this symbol, and this is the mystery. What was the missing data? So the missing data was a survival rate. We don't have information about our survival rate. So for this, we did a quick and urgent survey about survival for the 6 index cancer, WHO index cancer, and this allowed us to have an estimate survival rate. This is only a 3-year survival rate, but for previous studies, we know that the most important failure is due to early mortality. So we knew that 3 years can give some information about survival. And with this missing information, we were able to set an objective goal for our plan, which is to reach by 2030 80%, which seems feasible for our teams. So we were able to continue the process, so we set up our national implementation workshop, and we began our plan. So our workshop was set up on 21 January 2021. Sorry, it's 2021, not 2020, because at this time it was the beginning of the pandemic. And we selected our priorities. And as you can imagine, the problems are the same that are reported by Lorna. We need childhood cancer registry. We need quality of care for childhood cancer, from diagnosis, treatment, follow-up, improve drug accessibility, develop supportive and palliative care, and all these priorities are sustained by other priorities that are workforce training, governance, research, and innovation. So what are the progresses? We are trying to set up governments, strong governments that can give more liberty to the pediatric oncologists to develop their cancer plan. The analysis of the situation have been completed. We are doing a study on the costs of childhood cancer. It's in progress, and we are drafting our childhood cancer plan and trying to set up standards of care. This is all in progress. Childhood cancer diagnosis and treatment, and it will be national cancer registry, and we have our training program. We have a diploma, and we can give you more information about this diploma, training pediatric oncologists from all the Francophone Africa. We trained 100 from 19 Francophone African countries. So, what did we learn? First, what can be measured can be improved. So if you don't have data, you cannot improve the situation, and even if you improve it, you don't have information that you have improved the situation. So your input, what you will give at the beginning, will be data. Then you set up the process, and at the end, what will be requested from you is data. What was achieved? The second is human before stones. Start with building human resources before starting with stones. So my advice to the pediatric oncologists that are present here, take the lead of your program. Collect as much data as possible. Involve all your stakeholders. Then innovate, create. You are in a difficult situation. You cannot use a standard solution. Then provide results, which is data. Thank you very much.
Thank you very much, Professor Leila Hessison. Could I ask you to join us on the stage? If you need to collect anything, please do. We're going to have a discussion at the end with all the speakers. So I'd now like to invite to the stage Ms. Biemba Maliti, who is the Chief Nursing Officer of the Cancer Diseases Hospital in Lusaka, Zambia, and she's also President of the Zambian Oncology Nurses Society. So welcome, Ms. Maliti. We look forward to hearing about implementation of the GICC in Zambia, particularly from the nursing perspective.
Good morning, and I think my heartfelt thanks to the team in Uganda. It's my first time in Kampala, and I think a special shout out to Mariam. I first met her when she came to our National Stakeholders Workshop in Lusaka in 2020, just before COVID shut the world in, and I promised I would come to Kampala, and I'm honored to be here. So, as said, my name is Biemba, and I'm head nurse at Cancer Diseases Hospital. The Cancer Diseases Hospital is Zambia's only public facility offering chemo, radiotherapy, palliative care, nuclear medicine, and surgical services for oncology. And also from 2016, we have housed the pediatric oncology unit which is a 52-bed unit, but on heavy days, there are more patients than the number of beds. And we have 2 pediatric oncologists, Dr. Justin Mlindwa and Dr. Grace Chingo, who have specialized thanks to the Merck Foundation. So basically, I'm going to go through the background, where we're coming from, and then introduction, and then go through the various steps of where we've come from and where we are. So as already mentioned by several of our speakers, and I think as expanded by Dr. Kapambwe, by the way, she's very Zambian, and before she moved to WHO last year, she was the one who was running our cancer services at MOH, and she very much was the cornerstone of this coming alive. So basically in 2019 at Aortic in Maputo, that's where it was announced that Zambia had become one of the countries, and for us that was a milestone. Because prior to that, in our National Cancer Control Strategic Plan for 2016 to 2021, I think oncology, pediatric oncology only occupied a very small paragraph which only talked about retinoblastoma. So that meant that when you look at programming, obviously much of the focus was on cervical cancer, breast, and the others, and PED-ONC only got a small mention, meaning even resource allocation was not where it ought to be. So for us, this was a game changer. I will not go through that because I think Sharon did a fantastic job. So in 2020 February, we had our National Stakeholders Workshop. And I think the fact that I'm standing here today as a nurse should show you how much value I think our ministry and our programs have placed on nurses who, for most countries, make up 75% of your backbone for the health service. So we've been an integral part of this whole process from start. And even at the National Stakeholders Workshop, there was a very good representation of the nursing fraternity. We had nurse educators, we had palliative care, we had the oncology nurses. We do not have specialized pediatric oncology nurses per se, but what we have done as a country is we've ensured that the nurses dedicated to PED-ONC at least specialize in pediatric nursing for now. At least that kind of gives them a much better leverage in being able to attend to the needs of children with cancer. So we looked at achieving the objectives that were set for the country, which were summarizing the current landscape and priorities for cancer control. And Dr. Mlindwa and team did the profile project where they actually presented their report at this meeting, and then also introducing the concepts of the WHO cure-all, and then also being able to set realistic targets for us as a country and deliverables by which we could be able to benchmark our progress. And I think, as the previous speaker said, if you don't have targets, you don't have information, you will not see whether you're actually making any progress. So we defined core projects in order to be able to see how we were going to achieve these targets over the 3-year period. These targets were being set pre-COVID, so we thought in those 3 years we'd be able to achieve what we set for ourselves in alignment with our national, regional, and of course, global targets. And then COVID happened and upended our world. So our core projects were essentially top 3 priorities that we thought would be realistic to focus on. So implementation of the cancer workforce training packages, and then the national network and referral pathway strengthening, and then also defining national standards and guidelines for the index cancers. So the key themes with 13 priority projects and milestones: decentralization of care. Because at present in Zambia, like I said, pediatric oncology care is just centered at our facility. And we do have the Arthur Davison Children's Hospital on the Copper Belt, which does see some children with cancer and provide some kind of chemo, but it's not a dedicated pediatric oncology center. But it was one of the hospitals that took part in the profile assessments, and so it's one of the targeted decentralization zones. The other one is in Livingston, at Livingston Teaching Hospital, about over 500 kilometers south of the capital. So in time, we hope we can at least have 3 centers in the country. And then quality referral and access, diagnostic treatment, and also abandonment mitigation. And I think from the previous speakers, you can see that abandonment seems to be a recurring refrain. we would like all those who are diagnosed and have access to care to actually complete treatment. Then we can say we're winning. And then also we looked at focusing on developing guidelines. This is across the various disciplines that make up the multidisciplinary team, and of course training at all levels. So we had a planning meeting. This was of course delayed because of COVID, so we only had this at the end of last year, about October. We have the National Cancer Control Technical Working Group, which has committees. So there is a committee that focuses on childhood cancer. So one of the first things to do was to come up with terms of reference for this committee and what they were going to focus on. And these committees are usually made up of various players in the health landscape, civil society, various partners, and of course the healthcare workers and the policymakers. Then the next thing also at this same childhood cancer programming meeting was also now looking at how we were going to implement the planned activities after COVID started to die down, because obviously we had to go back to the drawing board and readjust some timelines. So after that, we had to go back to our National Cancer Control Strategic Plan, because the initial one from 2016 to 2021 was coming to an end. And since we had noted the gaps, we were happy that now we were going to actually write out an entire chapter, a much detailed document to include in the bigger country document. So we did this, and the team was comprised of various players in the pediatric oncology landscape. And so this was a 6-day working meeting, and then we looked at the client and stakeholder analysis, the situation analysis, gap analysis in line with the health building blocks, and then also what strategic direction we were going to take. And then we worked on the log frame as well, which went into further details of actually what we're going to do. And then also the implementation framework, and then also what was going to be put in terms of monitoring and evaluation framework. So this was a very intensive exercise. We worked hard, and I think we were happy to have come out of there with a draft document that, of course, was forwarded to the policymakers and the Directorate of Policy and Planning at Ministry of Health, so that they could polish it up and then fit it into the bigger national document. So after dealing with the strategic planning document, we now had to go into development of the Consolidated Childhood Cancer Management Guidelines. So currently, our country does not have childhood cancer guidelines, so to speak. And so to realign ourselves with the goals of the GICC, we had to work on this so that we can ensure that our targets of actually reaching measurable goals could at least have some streamlined tools to utilize that could standardize care across the continuum. So it was a 6-day meeting with 16 participants. Again, this involved everybody who is a stakeholder in the treatment of childhood cancer. So the pediatric oncologists, the radiation oncologists, the surgeons, the pathologists, the social workers, nutritionists, the nurses, and the pharmacists as well. So we worked in groups assigned to subgroups, and then there was a group looking at early detection and the referral pathway, and this also involved nursing input, and then there was pathology, then there was treatment. This also involved nursing, and then rational use of antibiotics and anti-cancer medicine safety. I think Dr. Kapambwe talked about drugs a lot when she talked about her presentation here, and then also palliative and supportive care, including survivorship, which also had heavy input from the nursing. So we had a wide array of reference materials to draw from so that we could develop something that was actually conforming to regional also and international standards. So these have been done, and they're yet to actually be polished and finalized and launched, hopefully before the end of this year. So that is where we were, and we did this at the end of last year. So one of the big things is that because of COVID, we've had to work at breakneck speed to sort of make up for lost time. Because from, I think, May 2020, when we started actually living with the reality of COVID, literally, our services, I think, became focused on containment and trying to mitigate the situation. So even meetings were canceled, and we just focused on keeping the cancer service running. So all this was shelved, and we only picked up momentum last year, starting from October. So our next line is going to be developing protocols and SOPs for childhood cancer management. So again, as nursing, we're heavily invested in the process because at the end of the day, like I said, we make up 3/4 of the workforce, and more than half of the time, we are the ones providing hands-on bedside care. We're the ones who help patients and their families navigate. And so we thought it's important that nurses are also vested in this process, and it's the only way we're going to make sure it actually works and people use these tools than they gather dust on some shelf. And also at the primary healthcare level, we have health facilities where you'll not have a doctor, but you're going to have a nurse. So it's important to have these health workers on board running with you at the same pace if we're going to actually see a reversal of the dismal, I think, stats that most of us are faced with in managing our patients. So next, of course, is our workshop for development of IEC materials. Again, because you want to get down to the primary healthcare level and see if you can raise awareness. We're also thankful to the unwavering support from St. Jude. Members of our team are also on the pediatric early warning systems program that is going on. So that is also going to help us a lot in ensuring that these ambitious goals that have been set up are going to actually become a reality. And then also next steps is the trainer of trainers for pediatric oncology programs. And I've been privileged to be part of the Sub-Saharan African Nurses NERTWEC, part of the steering committee that has actually produced a foundational curriculum for pediatric oncology. And 2 of my nurses are going to be in Malawi next week for a trainer of trainer programs. So this curriculum can be customized by countries, and we're trying to run with this. And I've set ourselves an ambitious target to have a pediatric oncology nursing program running in country from January next year. Because the Cancer Diseases Hospital, fortunately, does have a college that is domiciled on the campus. Right now, they're offering training for radiation therapists and also clinical oncology. So we're hoping to add pediatric oncology nursing to the portfolio of programs that are available. We do have 2 oncology nursing programs in country. One is a bachelor's program at the University of Zambia, and one is an advanced 1-year diploma at the Levi Mwanawasa Medical University. But these are looking at oncology in general, so we actually want to narrow down if we're hoping to change the narrative. So as a country, that's where we are, and I think it's a privilege as nurses to actually be considered equal partners, because I know we have this unending tug between nurses and doctors all the time, and nurses usually feel invisible, unappreciated, I think. But I think as a country, I would like to express gratitude to my government and our ministry, and in particular our hospital, for actually, I think, considering us as equal partners and driving this agenda together than just being handed down finished products and say, well, can you make it work? So for that, I'm truly grateful, and for having this privilege of sharing this information with colleagues across Africa. I hope that some of you can learn something from us. And I think for colleagues, SIOP nursing, they know that I'm only at the other end of a WhatsApp. Thank you very much for paying attention.
Thank you very much, Biemba, and for that very important final comment. Could I ask you to join us on the top table and ask the audience to be thinking of their questions for the discussion with the panel? So I'd now like to invite up our final speaker, Professor Alan Davidson, who's head of the Children's Cancer Department in Red Cross Children's Hospital in Cape Town, Africa, but today is speaking in his role as chair of the SIOP Advocacy Committee, which we, in fact, just founded formally less than a year ago. Alan, over to you.
That's my forward click. Oh, there we are. Thank you. Great. All right, fantastic. Thank you very much. It's wonderful to be here. Thank you, Joyce and the organizing committee for the invitation. So it's my brief to contextualize the GICC and its advocacy aspects in the context of what SIOP is doing in terms of advocacy. So I think I want to make reference to the investment case, which I think Sharon, you talked about it earlier, and I mean, it's a very simple algorithm. We know that 80% or more survival is achievable in high-income countries. We can also argue easily that the length and quality of that survival adds additional value. So it's not just a question of a few years of survival. We're talking potentially 60 years of additional good quality life in many cases. And then the relatively low cost of treatment has been not just suggested, but proven in some settings. Again, our colleagues in Ghana have helped, and there's published data on the cost effectiveness. Apart from that simple algorithm, good value for money, high quality, long survival, we also can add value as a community in terms of supporting universal health coverage, raising the quality of specialist services, and collaborating in terms of access to technology and drugs. So I'm not going to walk you through numbers. Suffice to say that where we measure in Africa and in most of low and middle income countries, we have age standardized rates that vary vastly from some areas in South Africa where it's been measured about 45 kids per million under 15, whereas we know in high income countries that number is as much as 130 to 150. So if you look at our context in Africa, given the population of the continent, with a conservative age standardized rate of 100 per million, we would expect 56,000 new cases of cancer every year. So that's the size of the problem. And again, I show you that, yes, I mean, the international community has not uniformly prevailed. We struggle with entities like neuroblastoma and myeloid leukemia, but in the majority, we have excellent survivals in places where we have very good resources. On the other hand, there is a massive gap, and this elegant little exposition is courtesy of Scott Howard, who many of you know, and it's a very important point. Follow the blue line. Even in places where your overall survival for those who are treated is in the order of 50%. If the access to care is low, if the other metrics, access to the ICU, issues like limiting treatment abandonment also fail you, then your real survival is probably 10%. And so even published metrics don't reflect the size of or the scope of the problem, if I can put it that way. So the consequence is this: from blue to red, the survivals go from low to high. And that's essentially what we seek to change. So the SIOP Advocacy Committee was brought about to try and actualize or concentrate the work of advocacy, which is really everybody's work. It's not, it's not up to a committee. We know it's up to the community. But the idea was to bring together people from both different competencies and different regions to try and bolster the advocacy argument. And I'm pleased to show you that there are three of us from Africa on that committee: Glenn Mbar, Koreda Akindele, and myself. So you could say that you are well represented. And what I want to talk about today is what we do. So essentially the work is divided up into two areas: collaboration and engagement. Collaborating with parents and survivors via Childhood Cancer International, collaborations in the research area, and I'll make very brief reference to that, and the issue of harmonization, particularly of protocols and guidelines, which is a massive canvas, which again falls in large measure under the GICC's umbrella in that sense. And then, of course, engagements, and you can see the crossover with WHO, with governments, and with international agencies such as St. Jude Global. So harmonization, I don't need words, I just need pictures. These are the many actors on our continent who are sponsoring a variety of protocols and guidelines. And you can see that the task of our community is to try and really get everybody on the same page, in simple terms. It's a simple goal, but you can appreciate a complicated journey. Then in terms of research, I want a shout out, if I can, to Philippa Masoko, who gave a wonderful talk in the YI session the other day. And this input was given at a SNOSA meeting in Cape Town a couple of years ago by Rakesh Jalali. It's a publication of his in JAMA Oncology, which addressed this massive question of how do we change the algorithm. You can see on the screen on your right-hand side that there is an inverse relationship between the amount of work you do and the amount of research you do. So the places that are massively overburdened with work, that is on the right-hand side, do very little in the way of publication, research and publication, and vice versa. And so how does one go about that? So Rakesh argued, and as did Philippa, and the essential point was at an institutional level, start with a registry, start with simple things, and build on that. We're trying to tackle as an organization that beast through the Program for Advancing Research Capacity in low and middle income countries. A committee's been formed. First meeting was in January. This goes by the name of PARC, so we all love our acronyms. And we are looking now with a little bit of financial capacity, not massive, but modest, at how we can kickstart initiatives. And I can tell you, if you have any ideas, our president in particular and myself are very happy. I've been writing down ideas through the last couple of days because we're very much in that phase at PARC of trying to figure out how we can best massage this problem with some limited resource and a lot of goodwill. In terms of the big, it was my first item, but I'm coming back to it because it's the most important. Our relationship with Childhood Cancer International is obviously critical. It's nice to see that these are all the CCI affiliates across the continent. It's quite a lot of work to do, but there's enormous progress, as anyone who's attended the CCI sessions will attest to. And you'll have an opportunity, if you're not in CCI, sneak into their sessions over the next couple of days. You'll be amazed. Our program is now a running, rolling process. We have International Childhood Cancer Day on February the 15th. We have Survivors Week in June, which is now going to have an annual symposium attached to it. First one was last year, which is very well attended. And then, of course, September, Gold September, is Childhood Cancer Advocacy Month. Now, using the Tree of Life and this whole wonderful kind of notion of painting hands with messages, we have a 3-year theme through our hands in last year, focusing on children and adolescents with cancer. This year has just been, of course, I hope that most of you all know that, through your hands, focusing on the medical team, and we emphasize that means everybody in your teams, right down to the janitorial staff. And then next year will be through their hands, focusing on families and caretakers. And in terms of SIOP's particular input, we struggled with the notion of a sort of a single slogan that would capture the SIOP's sense of this whole process. And we've come up, I have to credit Mike Sullivan, with trying to achieve the right treatment at the right time with the right support. And that's a sort of a distilling many of the things I spoke about earlier. And we'll be using that quite a lot going forward. Right. I think I've gone back. No. Sorry, my apologies. So, of course, to the centerpiece here, which is the question of how, where do we fit into GRCC and vice versa from an advocacy point of view. Now, I don't propose to speak at any length about the GRCC. You guys know the goal is 30% survival, is 60% survival by 2030, and that's very clear. But I want to illustrate a couple of points, and that is that the documents around this process are in themselves advocacy documents. There's a lot of advocacy thinking in all of these processes. So if you look at the 6 chosen diseases, for example, I'll pull out just one, and that's Hodgkin disease. And the reason Hodgkin disease is in the 6, apart from the fact that it has potentially an excellent survival, is because it throws light on adolescents and young adults. And So there you see there's advocacy thinking in the processes. If you go through the documentation, so we have myth busting, which we all know is part of what we need to do, but it's there in the packaged documents. So Sharon mentioned the levels of country engagement, and I always want to say that EMRO have Morocco, but they really belong to us, so you can say we're a +1 on the active list, at least 4 right now, 5 countries where there's conversations going on, and then, well, activities, I should say, not just conversations, and then several more where there are conversations happening. So there's progress, and we hope very soon to be able to show more progress in that regard. Lastly, I'll just make a point of the SIOP global mapping program, which itself is, it speaks to Leila's point about if you want to improve things, you need to measure, and so that's what the global mapping is all about, is measuring. And we started in Africa, and there are now several published papers, and those of you guys who've attended SIOP will have seen some of the reports from that initiative. I'm looking at Jennifer Hill, and I'm asking, are there not papers here also? Yes, there are. So please look out. Show how many? Is that 4 or 5? 4. So there are 4 papers here on the global mapping program. So you can look out for those, and just to show you the global mapping on central paper, just on the various capacities that we have, so it has detailed information on all of these areas. So very, very useful documents. And so that's me, just to give you a brief overview, and invoking Chichewe from Malawi, Pangono Pangono, or little by little. Thank you.
Thank you, Alan. So please come and join us at the top table here. So we've had a really excellent session, wide-ranging, and I hope you've learned a lot. Everyone's come away with something that they didn't know. I hope there will be some questions for discussion. There's a roving microphone. If you'd like to ask a question or make a comment, please put your hand up. Gentleman at the front here. And please introduce yourself and where you're from, and then ask your question. Thank you.
Thank you. Thank you very much. My name is Dr. Kunuz Abdallah. I'm representing the Ministry of Health of Ethiopia. I would like to thank all the presenters, and also particularly I would like to thank WHO and key partners for getting involved in promoting childhood care. Yeah. I was asked to stand. All right. So I believe there are quite rapid progresses in countries, and there are a lot of changes in countries. For example, in Ethiopia, just over the last 2 to 3 years, we have gone through a number of those processes, like setting up pediatric cancer centers in the country, 5 of them, having national pediatric childhood and adolescent cancer control plan costed, and we have done the assessments through the profile, and a number of activities are happening. So my question goes to WHO. I would like to understand what kind of, how frequently you are planning to review the global initiatives just to reflect those progresses in countries. And second, what are the mechanisms in place to engage countries so that you can factor in those progresses in countries? Because I'm just wondering the pace of development in countries and your global initiative. And so these two need to go in tandem so that we can see the changes in countries. Thank you very much.
Thank you so much for that question. And thank you also for acknowledging our involvement and the involvement of all the partners that are present. in terms of review of the GICC is a continuous program. And the engagement at country level, your first level of engagement as Ministry of Health is the WHO country office. And like I have mentioned, one of the key things that needs to happen in most of the countries, and you've said you've done some of the processes, is really you've seen the blocks that we gave the priorities, issues of doing a situation analysis, which is national assessment, stakeholders meetings. You've seen, I think, Leila and Ghana, Zambia, they talked about having a national committee or task force on childhood cancers that is looking into that. But countries are free to engage the country offices for WHO, and the country offices for WHO will engage the regional office, either if they are asking about technical support, or if they want to update us on what they are currently doing and the plans and activities, if they want their plans aligned to the GICC, for example. That is the type of technical support we're able to help. And also, it's not just WHO that is going to give you that support. WHO is working with all these partners. If we feel that SIOP is able to give you that support much more, we are working in collaboration together. St. Jude, it's the same. So it's not like we reviewed a country at the beginning and then we'll keep quiet and not review. This is a continuous process. It's a continuous engagement of countries, and we're not having a particular time where we say we are adding this country every 6 months or 2 months. No, countries are coming and saying this is what we have in place and we're interested in being a focus country. Or we just want to be a country in dialogue. These are the activities that we have. Are you able to support us with this? So what I would really request from Ethiopia, and I know we've been talking to Ethiopia and even the country office in Ethiopia about the activities that you're doing. If there's anything more engagement, we do have a three-way meeting, Ministry of Health, country office and regional office, and they will engage and we can come out with activities and bring in the other partners as well. I hope that helps.
Thank you for that answer. I've been informed we can keep this session going until 1:45, so we still have just under 15 minutes. So I'd like to invite, if any other members of the panel, particularly Leila and Biemba, might wish to comment on the question from the Ethiopian Ministry of Health about reflections of their own experience in their own countries. I know you've already given your talks, but maybe some short comment, and then there's another question at the back.
Thank you, Katie. So, as pediatric oncologist, before the beginning of the GICC, we have never heard before about the WHO team. But since the time we have been identified as a focus country, we began having a regular meeting with them. They prepared with us the implementation workshop, and 2 days ago we had our last meeting with them. And they are funding some, I'm sorry I didn't tell this, but some of the ongoing activities like cancer costs, standards, guidelines, they are funding those activities and doing follow-up with us.
I think in my presentation, I did allude to even other partners. I think we only became a GICC focus country in 2019, but we've had a long-standing relationship with St. Jude. And then I did talk about the Merck Foundation scholarships. So really, much like what Dr. Kapambwe said, there are so many players. I think even Alan alluded to this as he was talking about the synergy between SIOP advocacy and GICC. Find people who already have a soft spot for childhood cancer, because like I said previously, I think the world gets so carried away with adults that sometimes we forget about the children, and yet we know that our countries really, their future lies in ensuring the health of these kids. So you'll find that for us, we've had St. Jude in our corner, supporting many initiatives like for infection prevention, for example, sponsoring trainings. So don't look only to one person. And also, you must own these initiatives if they're going to survive. And you must also see, you will get support, but how will you ensure this thing does not die off once this support wanes? Because usually your support is for a very specific period. And it's a good thing that you said you're for the Ministry of Health. Identify who are your major stakeholders and contributors to success of your programs within your local landscape, and ensure you have them on the table even when you're just at the negotiating table. They must feel that they are part of the plan from the word go. That way you'll ensure that it's going to be sustainable and implementation will become a reality rather than just ending up on a drawing board.
Thank you very much. Are there further questions or comments? Please stand up. Yes, at the back. You have the gentleman in the yellow shirt. Please introduce yourself.
Yeah, thank you very much. My name is Ayire Adongo from Well Child Cancer, based in Ghana. Thank you, presenters. I think it has been enlightening and very good presentations. I think when the world comes together to do something in common, the energy is usually high and a lot can be achieved. In supporting some of the countries, especially Ghana, in the implementation of the GICC, one of the challenges that we were confronted with was the definition of a center of excellence. And I just want to talk about it. If WHO could help in defining what a center of excellence is, it will help us. And also, it's a very good initiative, but I didn't hear much about a committee for M&E, because it would be good to define track what the inputs, process, and output are. And particularly if we could have a public site where we can have a dashboard for implementing countries on key indicators that will be tracking on the implementation of the GICC. Maybe I haven't seen it. If it's somewhere, please let me know, because I tried visiting the site that you put up there, and it is on maintenance. Nothing can be seen.
Okay, thank you. I think we have two clear questions there. So who would like to take the first one about definitions of centers of excellence?
I think when I talked about a center of excellence, and I know is Nikhil here? Yes, Nikhil, do you want to come in? So, go ahead.
Sure. Nikhil Bhatta from St. Jude. Yeah, I'm happy to help jump in, and I think those are really important questions. And as you can see, there's if you haven't, there's the 100-page document that was created by the WHO technical team, whereby they kind of go through and define out each of the 4 pillars of which center of excellence is described. But frankly, we all know that a single normative value judgment of what a center of excellence is for each country is going to be an aspirational task, but not necessarily useful for treating the patient in front of us today. So really, it is about defining that at a local and regional level and identifying what are the pathways to developing that excellence. And so if that document is not available, we can certainly share that out through the Congress as well. I'm sure if that's helpful.
Thank you, Nikhil. I'd also like to add a comment, because I think the very vocabulary center of excellence, whilst it is an ambition, it also makes people who feel they don't carry that label to be not excellent. And I think excellence also means you can actually report your outcomes. So you've proved you had a good impact on the patients. And maybe we're still at the stage where we should be thinking more in terms of centers of expertise, which is, you're aiming to establish well-trained people, a competent workforce, sufficient capacity in order to deliver excellence. And there's a conversation I've had with Andre and Roberta in the WHO office. Maybe we should say centers of expertise rather than excellence, because that's really what we're trying to create at the moment.
And I think, in addition to what you're saying, Kathy, we always think of these buildings, which is having all the equipment and everything, and then we think, oh, wow, this is a center of excellence in our minds. But like I said, under the centers of excellence is that we're looking to have competent and sufficient staff. So it's really start ensuring that we have sufficient staff to look for childhood cancer. We're also ensuring that those staff that are working in those centers of excellence also are competent. Number and quality is very important, because you can find that, yes, you have the numbers, but they really don't have the competence that you're looking at. And so it will be a culmination of many things, but it's a process. And like Kathy has mentioned, we're moving. Maybe we start from expertise, but we're moving through this process of ensuring that we aspire to have, places, centers that are able to treat these children, and they're being treated by people who are competent to treat them, which means the workforce has been trained enough. All the workforce, we're not just talking about having, oncologists alone, we're talking that they have the palliative care. They can be able to give them survivorship information and how to support them through that process. That access of drug is happening at that level. So these are the processes, and different countries are at different levels. But it's also about how are we going to collaborate to help countries that are way below to reach where the others are. And that's where we bring in all this South-to-South collaboration. So yes, an aspiration, but it's important for us to know that there are certain things that we're looking at that will help us to have these outcomes of finally reaching the goal of at least 60% survival rate. Leila?
Just to give our experience in Morocco, we faced the same problem, because if we rely on what is published by the European group or North American group, this is not achievable for us. So this was identified as one of the priorities, is to put standards for the pediatric oncology centers, because we have the old centers with more expertise, the new ones that are developing, but they are having less experience, and they are having giving less quality of care. So within the GICC program, and supported by the WHO, we identified an expert, a national expert, which is aware about the local situation, but having an international background, so he can compare. And now he is working on the standards of care in pediatric oncology in Morocco. So this will be a specific recommendation and specific document for the country.
I think there was Emily that was mentioned. So we do have a community of practice as well on WHO, and we will be able to share much of the documents that have come in as well. But we're also looking at issues of cancer registration in these countries. That is a way of monitoring as well, and being able to evaluate, even to look at the survival that we have. So we're looking at hospital-based registration, which really also helps us to know as the children are getting treated and what is happening through the process. And then, of course, we have the general population-based cancer registries that are in the countries. And there's various support that is there, even with the International Agency for Research on Cancer. There's the African Cancer Registry Network as well. So, and we have our various partners that also look into cancer registries. St. Jude has helped some partners into hospital cancer registries, as well. And also WHO has looked into the indicators, and there are people who are working on the other side. But on the regional level, those are things that we're working with between the headquarters and the region to ensure that we bring in everyone and try to make sure that you're all understanding what are the indicators that we're looking at a much lower level and where we're going. So that is an engagement that we'll definitely go on and have, and there are available resources that we'll be able to share with you. Thank you.
So I'd now like to conclude this session. I know there were several hands up, but the speakers will all be out in the lobby in the coffee break. So I'd like once again to thank all of our speakers, including the excellent contributions that were pre-recorded online. And again, thank the organisers of this meeting for the opportunity to present this session at SIOP Africa 2022. We will have a full half an hour for coffee, so can I ask you all to be back in this room at 11:15 for the opening ceremony and our important dignitaries who'll be here to join us in that. Thank you.
And while we're outside, there's also poster viewing just by the tent, and also exhibitions in the tent.
Great.
And also to remind those who would like to test for COVID-19, there's a tent that has been set up just outside. Please make sure that you pass by if you don't want to be disturbed during your travels.
Every waking day is a reminder just how beautiful this, our land, truly is. The kind of beauty that you can only find here, in the lush green all around us and the wondrous sights within. It's in the distinct aroma of our cooking, to the taste of food that takes you on a journey, in the sound of homecoming and the sound of Mother Earth, in the magnificence we find on our travels and the exciting moments we experience. Ours is the kind of beauty that comes in all things big and small. All Every waking day is a reminder just how beautiful this, our land, truly is. The kind of beauty that you can only find here, in the lush green all around us and the wondrous sights within. It's in the distinct aroma of our cooking, to the taste of food that takes you on a journey, in the sound of homecoming and the sound of Mother Earth, in the magnificence we find on our travels and the exciting moments we experience. Ours is the kind of beauty that comes in all things big and small. All we have to do is awaken our senses and truly enjoy what's uniquely ours. Explore Uganda, the pearl of Africa. Every
you got 2 feet. Woo! And we can feel it. We can feel this thing. We can feel this thing. Oh, yes, we can.
You know, it's only correct after close to 2 years of not seeing one another. I'd like us all to just turn to your neighbor and look them in the eye and say, we can make a difference in the lives of children. Good to see you here. Let's give them a bonga and say, nice to see you. That's what we've been missing for the last 2 years. Great to have everybody here. So from everybody from the over 27 countries, we'd like to say a special welcome to you. It's great to be here. And it's good to be in the whole of Africa. You know, one of the wonderful things about Uganda, which so a lot of people might not know, is that we've got everything that you need in terms of tourism, yes. We've got the Pearl of Africa, that's the name. We've got the source of the Nile, we've got the equator. If ever you go touring and you find lions and chased up a tree, don't stay up the tree because lions in Uganda also climb. And 10% in certain places in Africa. And we want to be able to push that statistic up to over 60% by 2030. But how do we do that? And it's by working together. So the mere fact that you're here, that is a statement of intent that working together we'll be able to get something done. Somebody said that if ever you want to go fast, go it alone. If you want to go far, you go together. So it's going to be my great pleasure during the next couple of hours to be able to introduce people who are going to change lives. So starting first with an individual whom I actually happen to have gone to school with. I'm going to introduce her in the next couple of minutes, but in the spirit of Uganda and Africa, I know that this is a serious conference, but in Africa, we also have serious fun. So everybody who walks up here, we're going to inject some energy. Inject some what? That's it. So, ladies and gentlemen, please welcome the president of SIOP Africa, Dr. Joyce Balagade.
It's so easy.
Okay, I think dancing is a little bit beyond me right now. However, I'm very pleased. I'm very pleased to be here speaking to you all in my capacity as the president of SIOP. So, the Cancer Control Focal Point Department of Non-Communicable Diseases, Division of Universal Health Coverage of WHO, Dr. Andre Ilbawi, the Technical Advisor, WHO Afro, for the Eastern and Southern Africa, Dr. Sharon Kapambwe, the Country Representative for WHO, Dr. Waldemarian Tegagan, the SIOP President, Dr. Kathy Pritchard-Jones, the SIOP President-elect, Dr. Wilamo Shantada, the immediate past president of SIOP Africa and currently the president of GFAOP, Professor Leila Hessisen, the director of Sub-Saharan Africa region for the St. Jude Global, Dr. Nikhil Bhatta, the permanent secretary of the Ministry of Health, Dr. Diana Atwine, honorable members of parliament here present, the CEO of CHOC, Mr. Hedley Lewis, and the CEO of World Child Cancer, Mr. John Rosa, the chairperson of our board at the Uganda Cancer Institute, Professor Charles Oreni, the executive director of Uganda Cancer Institute, Dr. Jackson Rem, development partners, survivors of childhood cancer and their parents and guardians who are seated in this meeting. Dear members and colleagues of SIOP and SIOP Africa, as well as members of CCI and CCI Africa, all our other guests in your important capacities, ladies and gentlemen. I hope I haven't left anyone out. If I have, please forgive me. It gives me great pleasure to welcome you to the 14th Congress of SIOP Africa today in Kampala. First off, I want to thank you for coming to Uganda, despite the challenges that we are facing right now with the COVID-19 pandemic. This is a testament to the commitment you have to SIOP Africa and to the daunting challenge we face of improving the survival of our children from less than 10% in some areas to 60% by the year 2030. Today's Congress has attracted over 300 delegates from over 27 countries on the continent of Africa, as well as other countries beyond Africa. This has surprised us a lot, but pleasantly. There have been a total of 11 workshops, as well as 12 international societies represented at the 14th Congress of SIOP Africa. I will not mention them in the interest of time. These workshops have spanned various multidisciplinary teams that are involved in looking after children with cancer, including radiotherapy, including pediatric surgery, including pharmacy, including civil society, pediatric oncologists, nutritionists, among others. The Congress theme, Innovate for Africa, has challenged us to share scientific knowledge, to inform our efforts to raise survival of our children with cancer. Despite the constraints that we face, from resource constraints, from political unrest, from drought to famine, to many other things, we are determined to improve the survival of our children, to meet the target that has been set for us by SIOP, by WHO. And no matter what happens, we shall prevail. A robust scientific program has been put together by the scientific committee with 2 medical tracks, a nurses track, and a civil society track. We have eminent speakers in various fields from the continent of Africa and beyond that are going to speak to us over the course of the next 2 days. We are very grateful that they have accepted to speak to us at this meeting. I want to conclude by thanking all our sponsors, including Uganda Cancer Institute, including SIOP, St. Jude Global, Sanofi Espoir Foundation, University Hospital of Antwerp, Uganda Child Cancer Foundation, Uganda AIDS Commission, and others who have made this day possible. I also want to thank in a very special way the local organizing committee that has been composed of people from Uganda Cancer Institute, as well as our sister institutions and our civil society partners that have worked tirelessly to deliver this event successfully to all of us. Last but not least, I want to recognize the Department of Pediatrics at Uganda Cancer Institute, who have taken the slack while more than half of our members have been involved in preparing this Congress for more than 8 months. I want to thank you very much. So I want to conclude by saying that no child should die of cancer. Cure for more and care for all. Thank you.
Ladies and gentlemen, Dr. Joyce Balagade, President of SIOP Africa. Round of applause as she takes her seat. Thank you very much, Dr. Joyce. So, in African culture, it's always good to not speak to strangers. So, I think it's my great pleasure, ladies and gentlemen, to also signal the arrival of the Director General Health Services from the Ministry of Health here in Uganda, Dr. Henry Mbesa. Let's give him a big round of applause. Thank you very much. Up next, it's my great pleasure, ladies and gentlemen, to have the honor of introducing the SIOP President International. Please welcome Professor Catherine Pritchard as she makes her way to the stage.
and I want to offer my huge congratulations to Joyce and her team here and the colleagues at the Uganda Cancer Institute and all those stakeholders in the local organising committee who've made this Congress possible. It is a huge achievement that we are here, and I could already feel all that energy in the coffee tent outside, with the dancing, the wonderful Ugandan hospitable welcome, and the most important thing is we're all talking to each other, sharing our thoughts about the session we heard first at the opening around the Global Initiative for Childhood Cancer. And I'm sure we're going to make great progress today, and you'll all learn a lot over the next couple of days. When I go to many, I have been in the past at least to many meetings around the world, but certainly over the last 2 years, many on Zoom, which have been focusing on the regional needs for improving childhood cancer services and survival around the world. And that map of the world that's frequently shown, and whether it's looking at things like survival rates, presence of cancer registration to cover the population, the continent of Africa nearly always has lots of red in it. So it might look like, you know, a really big mountain to climb. But on the other hand, and I think we heard it in the opening session this morning on the GICC, that it's a mountain that we can climb together. And it's step by step. And we've seen some of the tools about how to go about engaging the people in your country that can help you realize the potential for curing children with cancer in your country, the resources and the skills, what it needs to make it happen, and to mobilize the supporters and stakeholders that you'll need to do that. And we heard very powerfully from Professor Leila Hessison about what she's done in Morocco, but in her past role as the previous SIOP Africa president, she's really championed the importance of personal leadership. And it's the people that are going to make this happen, not the bricks and mortar. Of course, you need good infrastructure in which to receive and treat your patients, but without good teams, and that's doctors, nurses, the pharmacists, all the healthcare professionals, and civil society, and the support of your ministries of health, and many others, and I won't repeat the long list of people to thank that Joyce mentioned, but we've seen the road ahead of us mapped out. The Cure All framework that's been co-developed by many people in this room, the WHO cancer team, the huge support from the St. Jude Global Program and many others, that road is mapped out. We kind of know what we need to do, and really now it's the implementation challenge, how to get there. And I think the title of this Congress today, Innovate for Africa. You know, as a continent, I think Africa has always been very innovative. There are many practices that have been born of necessity in Africa, which have been shown to be successful. And I think that by working together, climbing that mountain step by step, building on the work of others so we don't have to repeat things unnecessarily, we will get to that goal of achieving higher survival rates across the whole continent. And I'm sure many, many countries here are capable of going well beyond the 60% and others being well on that road. So to the Honourable Health Ministry of Uganda represented here, Dr. Jackson Oram from the Uganda Cancer Institute, and most of all Joyce and her colleagues, I want to congratulate you on the already the obvious success of this Congress, the presence of so many people here who are going to make things happen for children in Africa, the presence of civil society partners, and I wish you a very successful Congress. And thank you very much for inviting me to be here.
Ladies and gentlemen, Professor Catherine Pritchard-Jones. Professor, if you could kindly take your seat at the front here. Thank you very much. Let's give her a round of applause as she takes her seat. So we heard from Dr. Joyce, and Professor Catherine has also underlined the fact that Africa has its challenges, be they financial, be they the usual macro challenges. It can even be something as complex as mindsets. But what we need to do is that we must understand that we have no choice. we have to make a difference in the lives of children who have cancer. And what's been happening is that in Uganda, we have the Uganda Cancer Institute that has been working tirelessly with numerous other organizations to be able to try and make that difference. This is my great pleasure, ladies and gentlemen, to welcome the board chair, Professor Charles Olweny, to give his opening remarks. Round of applause as he makes his way.
Let me tell you something. Let me tell you something. Have you ever met those type of people that don't quite get it? They just don't understand what it is you feel when you hear Barbara Tucker saying, "I get lifted." They just don't understand when India goes into her prayer.
The Honorable Chief Guest, represented here by the Permanent Secretary, Ministry of Health, Professor Catherine Pritchard-Jones, President of the International Society of Pediatric Oncology, Dr. Jonas Tegan, World Marion, WHO representative in Uganda, members of the Board of Directors of the Uganda Cancer Institute, members of the pediatric oncology here present and those online, members of senior management at the Uganda Cancer Institute, invited guests, ladies and gentlemen, all protocol observed. I would like to begin my remarks by thanking the chief guest, the Permanent Secretary, Ministry of Health, representing the Minister of Health, Dr. Jane Ruth Acheng, for accepting the invitation to officiate as guest of honor at the opening ceremony for the International Society of Pediatric Oncology Africa Congress 2022. I would like to welcome members of the International Society of Pediatric Oncology who are physically present here and those online. I also wish to thank the organizing committee for preparing this conference and making sure that no stone is left unturned. Allow me to congratulate Dr. Joyce Balagadde Kambugu, the new president of the Pediatric Oncology in Africa and chair of the local organizing committee. The late Dr. Paul Carbone, who was at that time head of medicine branch at the National Cancer Institute in Bethesda, Maryland in the USA, traveled across Africa between 1965 and 1966 in search for a suitable location for a cancer center in Africa to be supported by the National Cancer Institute in the United States. He started in South Africa, then went to West Africa, then North Africa, and when he came to East Africa and visited Mulago Hospital in Kampala, Uganda, he exclaimed, "I have found what I've been looking for." He was impressed by the epidemiological study of Burkitt's lymphoma undertaken by a surgeon at Mulago, namely Dr. Dennis Burkitt, and the work of the late Professor Sebastian Chalwazi in various tumor types. The Lymphoma Treatment Center was headed by Dr. John Ziegler from the National Cancer Institute. The Lymphoma Treatment Center was funded fully by the National Cancer Institute and opened its doors in 1967 for the treatment of Burkitt's lymphoma and childhood Hodgkin's disease. The success of the Lymphoma Treatment Center led to the founding of, excuse me. The success of the Lymphoma Treatment Center led to the founding of the Solid Tumor Center for the management of adult tumors, namely Kaposi sarcoma, hepatocellular carcinoma, and malignant melanoma. The two units came to be known as the Uganda Cancer Institute. In 1971, an international liver cancer conference was held at Makerere Medical School. And Dr. Carbone and Dr. Ziegler during that conference convinced me to pursue an oncology fellowship program at the National Cancer Institute. My Master of Medicine and Med dissertation was on adult Hodgkin's disease in Uganda, and Dr. Ziegler was my supervisor. I left for the National Cancer Institute in June of 1971. My fellowship embraced adult oncology and hematology program, pediatric oncology, and laboratory training. In March 1973, I received a message stating, "If you do not return now, you will find nothing to return to." Idi Amin had expelled all Indians, and many Europeans and Americans were forced to leave Uganda. On arrival, I reported to the then head of medicine, the late Professor John Kibuka Musoke, who told me that the Cancer Institute was under the Department of Surgery and asked me to report to Professor Chalwazi, who at that time was head of surgery. When I expressed my inability to head the Cancer Institute, Professor Chalwazi held my hand and said, "Son, don't you worry, I'll be there to assist and support you." He lived up to his promise, and he used to come once a week for a joint ward round with me, both at the Lymphoma Treatment Center and the Solid Tumor Center. In my new capacity, I replaced 6 American and 1 British doctor. I would do my ward rounds in the morning, and in the afternoon I would spend most of the time in the research laboratory. I eventually decided to close the laboratory and concentrated on clinical work. I also decided to engage smart medical students to assist with the clinical care, especially after office hours. The National Cancer Institute used to supply all cancer drugs and supportive care drugs to the Uganda Cancer Institute. It stopped doing so when all American doctors were forced to leave. Apart from staff shortage, lack of appropriate drugs was the next major challenge. I responded by seeking audience with His Excellency Idi Amin Dada in his office in Entebbe. At the end of our discussion, he was convinced and promised to give full support for cancer drug purchase. I received money on a quarterly basis and traveled by road to Nairobi to buy cancer and supportive care drugs. The theme of this Congress is Innovate for Africa. To me, innovation means making changes that help the society or community where we are. In this regard, I wish to share with you the concept of essential drugs in oncology, which began at the Uganda Cancer Institute. In 1975, the head of oncology at the World Health Organization headquarters in Geneva, Dr. Jan Stansford, visited the Uganda Cancer Institute. After ward rounds with him at the Lymphoma Treatment Center and the Solid Tumor Center, we had a break for tea. During the discussion, the issue of drug shortages in Uganda emerged as one of the challenges. I made a statement to Dr. Stansford: if I had only 5 drugs constantly available, I would practice good medicine anywhere in Africa. He then asked, what are these 5 drugs? In my response, I stated I needed aspirin for pain, chloroquine for malaria. Those were the days before chloroquine resistance emerged. Ferrous sulfate for anemia, because the commonest anemia globally is iron deficiency anemia. I would need one broad-spectrum antibiotic, and I would choose chloramphenicol because it has a broad spectrum and it is cheap, although I would be mindful of its potential side effects, namely aplastic anemia. I would choose one broad-spectrum antihelminthic. In response, Jan said, "But you are an oncologist. Do you have a similar list for oncology?" I went to my office and came back with my list of 10 drugs. He browsed through the list, folded the paper, and put it in his pocket. 2 weeks later, he called me from Geneva to say he was organizing an international workshop on essential drugs, and he wanted me to give the keynote address. I accepted the challenge and traveled to Geneva. Participants at the conference were from Argentina, Australia, Brazil, Canada, Germany, Norway, Sweden, and the United States of America. I was the only participant from Africa. After my presentation, the group of 30 participants split into 3 groups, and each came up with what they considered to be essential drugs list for oncology. The 3 groups then shared their findings at a plenary session. The final list was a replica of my list. They added only one other drug. They added only one other drug, namely cisplatinum, which was necessary for treating curable testicular cancers. I had not included cisplatinum because testicular cancers were rare in Uganda at that time. Thus, the global concept of essential drugs in oncology began at the Uganda Cancer Institute. The Uganda Cancer Institute is now a center of excellence in oncology. We have been told maybe we should change to a center of expertise. It is an autonomous institution and fully funded by the government of Uganda with support from multiple research grants. Uganda Cancer Institute stands on 3 key pillars, namely care, research, and training. A total of 36 papers were published in refereed journals last year. There are 202 students undergoing treatment in various fields in oncology, with the largest group being pediatric oncology with 15 trainees currently. The trainees are mostly from East Africa, but currently they are trainees from West and Central Africa as well. Uganda Cancer Institute infrastructure currently includes a 6-level cancer ward built by the government of Uganda, the Fred Hutchinson Cancer Center, hosting various research laboratories, and an outpatient clinic and administrative building nearing completion, funded by the African Development Bank. The Uganda Cancer Institute has regional cancer centers, with Gulu for the northern region, and construction is to be completed in 6 months. Mbale for the eastern region, Mbarara for the western region, Arua for West Nile, and in Zambia for the central region. I hope you will find time to visit the Uganda Cancer Institute headquarters on top of Mulago Hill before you return home. I thank you all for listening to me.
Ladies and gentlemen, Professor Charles Olweny, Board Chair, Uganda Cancer Institute. Big round of applause as he makes his way down. Professor, if we can kindly ask that you take a seat there at the podium too. Thank you very much. Let's give him a round of applause. All right. So, So what's your name?
My name is Isaiah Sosi Brandon.
Brandon. How old are you, Brandon?
I'm 8 years old.
8? But you look old. You must be like 25. Are you sure you're not 25?
Who said so?
Mom, I'm looking at your height, huh? What do you do in your spare time, Brandon?
I watch TV.
TV?
Yes.
You don't like sports?
I like
What type of sports do you like?
football.
Football, huh? What's your favorite team?
Arsenal.
Oh, I'm sorry for you. Me, I support Manchester United, but we're not doing very well either. I think we should pray for both of us. Do you want to change your team to like Liverpool? They seem to be fluking many good games. You want to change?
No.
Okay, fine. All right, so, and what school do you go to?
Kaboja.
Kaboja. All right, and what class? Let me see. You look like you're in P7.
No.
No, what class are you in?
I'm in P3.
P3?
Yes.
Wow. What do you want to do when you grow up?
I want to...
You're still thinking. You know, there's so many things you can do. You can be a president, you can be a doctor, you can be a firefighter.
I know, but I've not yet chosen what I wanted to be.
Okay. You haven't yet chosen. So I think you people have a chance to impact on his life. So I heard very concerningly that you're a bit unwell and you're being treated. Tell me what's been happening, okay? And tell me how you're feeling now.
I'm feeling okay.
You're feeling okay?
Yes.
All right. So what's been happening is that Brandon has been suffering from leukemia, but he's at the tail end of his treatment, and he, as you can see, is feeling a lot better. Let's give him a big round of applause right now. In fact, I want to give you a bonga. I said, you're a very brave young man. I want to give you a few minutes to walk onto that stage. Brandon has taken time out and prepared a wonderful poem for us. So I want you to walk up on the stage, and I want you to give us that poem. All right? Let's give him a round of applause. Brandon, that moment is yours. Right there. Stand right there. All right.
Hello, my name is Isaiah Sosi Brandon, and I'm going to recite a poem called The Littlest Soldier. The medals on our chests, a pot, a cat for maids, helmets won't stay on, 'cause no hair is on our heads. Our weapons of distraction we take every day. We fight the battle within us while we struggle on to play. We fight with honor and courage. No marine could do us well. We are only little children living in this hell. So bring out the medals, the purple hearts of war, the golden cross, the silver star, to place upon our scars. For we are the children of cancer. No one has fought so hard, but every day we struggle on. Our life is our reward. Thank you, ladies and gentlemen.
Thank you. Powerful. DJ Low. Well, there you have it. Let's give a big round of applause to Isaiah. Let's give him a standing ovation. So, Isaiah happens to be one of the children from the Uganda Child Cancer Foundation, and we've been working together with him. Come, Isaiah. You are a very powerful man. You know what? Low. You know what I'm thinking? When you are thinking about what to do in the future, okay? Why don't you also consider being a master of ceremony on the microphone? Because you're very confident, huh? You want to consider that?
No.
Okay. I'm trying to impact in his life, but it's not working. All right, let's give a big round of applause to Isaiah. Thank you very much, Isaiah. The kids of these days, they don't know what's good for them, huh? All right, so ladies and gentlemen, before we call our Our guest of honor, it's my great pleasure now to welcome the Executive Director for the Uganda Cancer Institute. Please welcome Dr. Jackson Orem. Round of applause as he makes his way.
Our chief guest for this morning, who happens to be the Permanent Secretary, Minister of Health, standing in for the Minister of Health. The Permanent Secretary is Dr. Diana Atwine, and the Minister of Health is Dr. Jane Ruth Acheng. The Director General of Health Services, Dr. Henry Mebesa. The WHO representative to Uganda, Dr. Yona Stegen. The Chair of the Board of the Uganda Cancer Institute, Professor Charles Olweny. The President of SIOP, Professor Catherine Pritchard-Jones. Ladies and gentlemen, in your different capacity, allow me to say all protocol observed. I want to take this opportunity to welcome you to Uganda in a special way. It is really an honor that even within a very short notice, when this conference was transformed from being 100% virtual to being mainly in person and some segment being virtual, to see such a large number of delegates coming to Kampala. This to me is a vote of confidence that you have in our country and perhaps also in the measures that we have taken in the fight against the deadly COVID. To see all of you here, to me, is a big endorsement of the safety and all the other measures that our government has put in place. So a round of applause to our government. Allow me to go straight to what really I want to say. Listening to the presentation that has been going on over the last few days and also this morning, one cannot really stop at just thinking of what is going on in as far as the field of pediatric care is concerned in Africa for those children who are suffering from cancer. Of course, Professor Charles Olweny has already given a very good background to the initiatives that has been taking place ever since in the field in Africa. Of course, he talked about the establishment of the Uganda Cancer Institute way back in the 60s. That came about as a result of international collaboration as well as focus on children. So when you hear the presentations, it looks like Africa tends to be just going in circles and not kind of making progress. And I think, to me, that is something which needs to be changed. Because there have been initiatives in the past, you can say starting from the 60s. The Uganda Cancer Institute was established precisely as a research institute for childhood cancer, because at that time, in 1958, a new cancer was discovered here called Burkitt's lymphoma. And that cancer actually turned out to be of great premise in as far as research into cancer care is concerned. I can say that a lot has been done in as far as Burkitt's lymphoma is concerned. Up to today, there is no single world-class laboratory in the world that does great science without having the bedrock of the scientific initiatives that were done here at the Uganda Cancer Institute and, of course, in other African countries, be it in Ghana, be it in Nigeria. All those days, actually, the focus of science was on that new cancer that was prevalent in Africa. So one asks himself or herself, why is it that every time Africa is still being thrown at the back when actually Africa was at the front in as far as research is concerned, in as far as the development of treatment of childhood cancers was concerned. Professor didn't go to talk about the initiatives in the treatment of cancer, for instance, the development of combination chemotherapy. In the 60s, actually, cancer treatment was still mainly a research endeavor. And most of those researches in terms of the combination chemotherapy, how they can be provided, were actually done here in Africa at the Uganda Cancer Institute, and by extension also to centers in Ghana and Nigeria. So we can say that actually Africa has been at the forefront of initiatives for treatment of cancer in the world. So to see that we are actually at the back at this point, to me, I think it is showing that Africa is going round in a cycle. The second point that I want actually to bring out is the consistent achievement that the Uganda Cancer Institute has made ever since. Professor Olwen talked about the dark days of Idi Amin, as well as in the 80s when actually we had a lot of turmoil in our country, and then of course the coming of HIV. All those aspects actually impacted on the operations of the Uganda Cancer Institute. But one thing that I can say is that we as a country have never lost focus of management of cancers in children, and up to now, our children are being treated at the Institute, and it has always been actually a focus of our endeavor. So, we want to be part and parcel of what is going on, and we want to mobilize within Africa what we are doing. We don't want to have those segmented ways of doing things. The progress that has been made ever since those early days, we need to see them being brought on board. We need to see them being recognized. And in this aspect, actually, at this conference, we have a very powerful book that has been written on the history of all these endeavors, starting here at the Uganda Cancer Institute, and also highlighting some of the other aspects that has been going on in other parts of Africa. It would be really a great pleasure for each of you to get hold of a brand new book called Africanizing Oncology. And the author is here. I hope she'll get time to launch her book. Marisa Micah actually has written a fantastic book that can show you the potential of innovation that Africa has. And I think if we can add this to the emphasis that SIOP is making, I think it will make Africa leap instead of Africa restarting every time there is a new initiative. Lastly, let me share with you some of the achievements that the Uganda Cancer Institute has made in terms of being at the forefront of the implementation of our National Cancer Control Plan. And in this, I want also to applaud our government for actually thinking outside of the box. With the plethora of other conditions, including infectious diseases and all these other things that make, in most cases, our government to forget focus on other emerging problems like cancer situation, our government decided to establish a fully fledged government agency to look at only one thing, and that is cancer. And that is the Uganda Cancer Institute, established by an act of parliament in 2016. And its focus is to make sure that there is full implementation of our National Cancer Control Plan. And I think there are very few countries in Africa that is doing that. Secondly, our government has made sure that actually the issue of access to medicine is dealt with. And this it has done in a very innovative way as well, by ensuring that the Uganda Cancer Institute deals directly with manufacturers of drugs. And today, I can assure you, our access to essential anti-cancers and also including some rare elements now stands at 85%. And this is actually in excess of what WHO recommends. WHO recommends actually that our target should be at 80%. Uganda has now achieved 85%. And this is something which can also be emulated by other countries. Thirdly, we are decentralizing our services by the creation of what we call regional cancer centers. We don't want people to travel far to come and access care, and we are building these regional cancer centers, and the professor has already talked about. We want access to all cancer services to be closer to the population. Fourthly, the Uganda Cancer Institute is also helping the East African Community member states to develop standards and also to improve on care through the East Africa Center of Excellence in Oncology, which is here at the Uganda Cancer Institute. And I'm proud to say that pediatric oncology is at the forefront of the implementation of the agenda of the East Africa Center of Excellence. We have created fellowship programs for pediatric oncology. Next, we are also going to actually have nurses and all the others. Finally, in terms of quality of service, the Uganda Cancer Institute ensures that our practices are harmonized, as well as having guidelines and following those guidelines and making sure that practitioners actually toe the line in as far as providing care is concerned. That means that actually there is uniformity of the way we do things. There are many other things that can be learned out of what is being done at the Uganda Cancer Institute, and we want to be part and parcel of the GICC initiative because there is already a lot that we can share with the rest of Africa. And that said, I would want to end here by once again thanking you all and for the many initiatives that is going to be shared in this conference, and I hope at the end of the day, Africa is not going to again move in a circle. Thank you.
Ladies and gentlemen, Dr. Jackson Orem, Executive Director for Uganda Cancer Institute. Let's give him a round of applause. Ladies and gentlemen, and our final speaker before we call our guest of honor, please welcome with me the World Health Organization Country Representative for Uganda, Dr. Jonas Woldemariam.
The guest of honor, Dr. Diana Twinney, the Permanent Secretary of Ministry of Health, representing the Honorable Minister. Thank you for being with us and for your great leaderships of this country's health sector. Honorable members of Parliament here, because I know that Uganda Parliament is one of the most committed in addressing cancer in this country and could be an example for other countries. The Director General of Health Services, Dr. Henry, for providing us technical leaderships in this area and your great collaboration with all the partners. Professor Charles Oluweni, thanks for being here. When I realized a colleague of mine told me a bit about you, I realized I'm standing with a giant. Thank you for your contribution. Dr. Jackson, for your leaderships of one of Africa's great health institutes and keeping it in the direction of serving Africa at large. Professor Catherine, I think no words would say that you managed to make this institute, this scientific group of pediatric oncology come to Uganda, and for helping our African chapter to grow. Thank you for being here. Dr. Joyce, my apologies. In Ethiopia, when we respect people, we call them by their first names, and by now you should be very well versed with this. So, Dr. Joyce, the African SIOP president, for taking this mammoth task at a very difficult time. Probably a few months ago, if somebody says that you would organize this, you would say, maybe only virtual. But you made it, and thank you for that. Distinguished scientists, our guests from all over the world, and to spare myself from the embarrassment of that I might have forgotten some of you, all protocols observed, ladies and gentlemen. I congratulate the officials of SIOP and the organizers for really a successful scientific conference. I'm happy, humbled, and honored to attend this international conference on pediatric oncology, African Congress, with a theme which couldn't have been any better, Innovate for Africa, that will update us on the best practices and innovations for averting preventable childhood mortality due to cancer. Worldwide, cancer is becoming one of the leading causes of death for children and adolescents between the age of 0 to 19 years, accounting to over 400,000 deaths annually. 400,000 kids and teenagers. That's too much. Even one child loss of preventable disease is acceptable, not acceptable for any of us. Over 28,000 children die from cancer in sub-Saharan Africa during even this COVID-19 pandemic in 2020, according to the report of WHO 2021. An estimated 2,834 new cancer cases were diagnosed among children aged between 10 and 14 years in Uganda in 2020. This, we believe, is an underestimate since the Lancet study, which showed us that we have a proper cancer registry in a very few countries in the sub-Saharan Africa. Lymphomas, nymphoblastomas, copsisarcomas, retinoblastomas are the most common pediatric tumors in Africa. Although most children cancers have high cure rates of up to 80%, only 20 to 30% of children in cancer in low and middle income countries survive compared to over 80% in high income countries. Just like what we saw in vaccine access, here also in cancer, we see a very dark red map, which is showing us the inequity in the world. And this gathering should enable us to innovate and make change. In Uganda, most children with cancer have a less than 60% 3-year survival rate apart from Hodgkin's lymphoma. Although Uganda is one of the best achievers in survival and giving services. A low survival rate for childhood cancers is due to inadequate capacity of health system compounded by profound lack of awareness by the affected people, leading to a late diagnosis and treatment. Only 29% of low and middle income countries have adequate level and range of access to cancer medicines compared to 96% in high income countries. As you are already aware, in response to the World Health Assembly resolution on cancer control through an integrated approach, WHO, in collaboration with St. Jude Children's Research Hospital, launched the Global Initiative for Childhood Cancer in 2018 with a target of at least 60% survival of all children with cancer by 2030. This initiative requires a doubling cure rate to save 1 million more lives. Allow me to mention some of the WHO tools for childhood cancers. The Cure All framework and technical package for implementation of the initiative. The information sharing portal to facilitate sharing of expertise between countries and partners. The first global platform for access to childhood cancer medicines based on best care standards that was launched in 2021 in collaboration with St. Jude Children's Research Hospital. WHO and the International Agency for Research and Cancer, IRAC, collaborated with the International Atomic Energy Agency and other UN organizations and partners to develop standards and tools to guide the planning, implementation, and interventions, including early diagnosis, treatment, palliative care, survivorship care, and access to essential medicine and technology. WHO is committed to provide technical support to governments and partners to reduce the inequity in childhood cancer diagnosis and treatments, and hence to contributing to the progress towards the achievement of the Sustainable Development Goals, specifically 3.4, which namely says that reducing preventable mortality due to non-communicable disease by 1/3 by 2030, and target 3.8 on universal health coverage, including financial risk protection, access to quality essential health care, and access to safe and effective quality of affordable essential medicine. I have an ask for all of you, especially those of us coming from countries in the sub-Saharan Africa. The first ask is, let's make sure we have the information, which is reliable, because that is important to guide our plannings and activities. Such information is important to our politicians because it's reliable, accurate information which would make a change in decision making. Let's make sure we have adequate human resources in our countries. Let's make sure we have a comprehensive cancer control strategy and plans to lead us in this direction. Instead of having scattered services, probably having centralized services might be a way to start, as we can see in Uganda, that was able to push the drive nationally. Let's lobby our parliamentarians, decision makers, and governments for adequate funding and ensuring there is a multi-sectoral action with all partners on board. And let's also focus on prevention, early diagnosis, and also addressing the environmental factors. In conclusion, allow me to emphasize that high-quality epidemiological data is central to improving cancer care, and therefore robust childhood cancer data systems are fundamental for driving continuous improvement in the quality of care and evidence-based policy decisions. I thank the Uganda Cancer Institute, the national and international pediatric oncology chapter, distinguished scientists, everybody who has made it possible for us to reflect on how we can fast-track implementation of the initiative to reduce preventable mortality and morbidity to childhood cancers. Let me take this opportunity to remind you that although we are having fewer and fewer COVID cases, we are not out of the woods, and we need to follow the public health measures for preventing transmissions. I hope all of you are vaccinated and boosted. If not, make sure you are vaccinated and boosted. I also urge you to take the opportunity of coming to Uganda for our visitors to visit this beautiful pearl of Africa. I thank you.
Ladies and gentlemen, Dr. Jonas Wildemariam, WHO Country Representative. Thank you very much, Doctor. It's my great pleasure now to ask Dr. Jackson Orem to come back to the podium to introduce our guest of honor. Let's give him a round of applause.
Thank you. Once again, it is my great honor and privilege. I take it as an opportunity, and I want to break protocol and skip Dr. Henry Mebesa so that the honor is on me to invite our chief guest this morning. Our chief guest this morning, as I stated earlier, is the Permanent Secretary, Ministry of Health, Dr. Diana Atwine, who is standing in for the Minister of Health. Dr. Diana Atwine is a very passionate, strong advocate, professional, name it, in as far as the health sector is concerned. She knows the sector in and out. She's an hands-on administrator, somebody who always goes and is at the spot. I was really humbled to get her to come and officiate at this conference at a very short notice. So I can go on and on and on, but it is really my privilege and honor this morning to invite Dr. Diana to come and make her speech.
The Director General of Health Services, Dr. Henry Mwebesa, the country representative of World Health Organization, the representatives of World Health Organization from the region, the President, SIOP International, Professor Catherine Jones, whom I've really excited to meet because I've heard about you and this my opportunity to meet you, President-elect SIOP International, the chair of the board and one of our icons in our country that we take pride in having, Professor Olweny. I believe in his keynote address, you've been able to know the contribution he has made in this country. The Executive Director, Uganda Cancer Institute, the President of CCI Africa, the President COP Africa, the survivors of cancer and the parents and the guardians of the survivors, the senior officials from Ministry of Health and the oncologists in the country and abroad, dear distinguished delegates from Africa and abroad, outside Africa, the development partners, in the interest of time, ladies and gentlemen, I observe the protocol. It is my great honor to stand here before you to open this 14th African Continental Congress of the International Society of Pediatric Oncology. I bring greetings from my minister, who was assigned the duty abruptly and she had to travel, and so she could not be here with us. But I want to tell you she's here in the spirit. She left, but her heart was here. And so I bring her greetings and apologies. Before I read her speech, I just wanted to make a few remarks as the Permanent Secretary of Ministry of Health. As a physician, as once a clinician, and who knows what it takes to take care of cancer patients. First of all, I want to thank you for the theme of this conference, how Africa can innovate to do things a little different to achieve our targets within the circumstances that we operate, within the resources that are at our hands, and within the context of other disease burdens that compete with the cancers in our country. How do we innovate to improve access to care? You have heard that in middle income and low income countries, the survival rate stands at 20%, while at high income stands at 80%. That means if we are going to get to our target of above 60, we have to do things differently. We may not all of a sudden wake up and we have all the resources that we need in the country or on the continent. But it is our day and duty as we stand in our respective capacities from our countries, that we have a duty to innovate. Innovation means you think out of the box in order to deliver within what you have. Innovate means you are going to start thinking differently, and approaches must be different. A lot of research has been done in Africa, and in Uganda in particular. You have heard Professor Olwen take us through the journey of cancer care in Uganda and in Africa. A lot of publications have been made, and we continue to do publications and more research. But we want to see Africa take another level of research, own research, implement the findings of the research. We want to see go higher in our implementation, that we improve the issue of governance. And I was very glad when Dr. Sharon, when she was here, she really talked about governance. Governance, it is not just the structure. Governance is about implementing the policies that are actually going to transform, to implement the policies and the regulations and the protocols that are going to get us there. As I stand here, I want to commit, and I was excited to have opportunity to meet the team led by Catherine yesterday, and we discussed more on how we can be part of this global initiative that has stepped out to enhance care of childhood cancers. And I want to commit on behalf of government of Uganda and on behalf of Ministry of Health that we are going to put structures that will accelerate us to get to that level where we want. And I'm glad when I was chatting with the executive director, because I had not had opportunity to look at the statistics in the country on childhood cancers. I want to report to you that our survival rate in the country is at about 50%, which is slightly above than the average of the middle income or sub-Saharan statistics. But we still have a long way to go, because even 60 is not sufficient enough. 60 is simply barely the minimum we should target to. But we need to get to 80%. If the other countries can do it, it is very possible that we can do it. And therefore, we have a big task at our hands when we talk about Africa innovative way of getting to 80%, because no child should die of cancer in this era and age. When we know what to do and how to do it, we know that we still struggle with financing. We need to leverage financing and take advantage of the partnerships that are existing. Yesterday, I was so excited to hear about the work of St. Jude and what they are doing on the continent. We need to leverage and enhance those partnerships, true partnerships, because sometimes we have seen partnerships that come and they are skewed to certain areas, and you find that it's not a mutual partnership, but it is consecutive to meet certain targets of the funders. But here we are talking about real, true partnerships that are mutual, and we stand together. If we do research together, and we are recognized together. If we bring resources, we put it to the real need, and those resources to make the difference in the lives and the survival of our children. Therefore, I want to say for me, on my behalf, and on behalf of our Ministry of Health, we are excited to host you here. But most importantly, we are excited to see the mood, the commitment, the zeal. I was looking through the papers that are going to be presented, that have been presented in this room. I participated on Monday on retinoblastoma meeting in Munyonyo, and I heard the papers that were presented. And I was excited because the mood is that we can do it. The mood is that we shall do it. The mood is that we are able to do it. And we can put in place the mechanisms that help each nation, especially the low-income countries, to get up to our feet and run. It is very possible. And I'm very, very excited to be here and be part of this meeting. Allow me quickly to read through the speech of the minister. It is great honor to preside over the opening of the 14th African Continent Congress of the International Society of Pediatric Oncology. This much anticipated meeting has brought together members in Africa and international community to discuss the critical matter, which is, what must Africa do to increase the survival of our children that have cancer? I am aware that this Congress was to be held last year in January 2021, but due to COVID pandemic, which caused unprecedented worldwide paralysis, this did not take place. Nevertheless, the fact that Uganda has honored her promise to convene this meeting indicates the seriousness we attach to this matter. Each year, as you heard from WR, 429,000 children and adolescents worldwide develop cancer, and of these, 80% live in low and middle income countries. Almost 40% in Africa. That is a big number. Survival in low and middle income countries include much of Africa is less than 30%. Yet we know that survival rates as high as 80% are achievable. Even my minister believes that it is achievable. Colleagues in high-income countries have achieved it. Why not us? As Africa gets better of infection-related mortality, cancer is emerging as a leading cause of mortality in this age group, and we must rise and do something about this. Fortunately, the causes of poor survival are surmountable, including treatment. Unfortunately, the causes of survival are surmountable, including treatment, abandonment, as you heard in the morning in the presentation by Dr. Sharon, misdiagnosis or failure to diagnose at all, late diagnosis, among others, as have been mentioned by the previous speakers. The World Health Organization launched a global initiative of childhood cancer in 2018 with a target of 60% childhood cancer survival globally by the year 2030. As we know that better survival can be achieved through our hands. The Congress theme, Innovate for Africa, challenges us all to find innovative ways to improve survival of children with cancer in Africa, despite the resource constraints that are prevalent in our countries. The government of Uganda has been and is still committed to ensuring that all patients, in particular children and adolescents with cancer, receive the highest quality of cancer care. We are not yet there today, but we'll get there step by step. And I will not go through the things that so far government has done because I think the executive director mentioned them all. One of them is enactment of the law to make sure that we give full autonomy the Cancer Institute to make decisions and resource for financing so that they are able to fly, to spread out their wings without any limitations. And that one, we have done it. And thus, I want to tell you that it is one of the reasons why Cancer Institute has been able to even increase access to care, to increase the availability of medicines, because they are now free to really look for resources without any hindrances. Because, you know, in government, if you are going to look for resources under our mainstream, their processes are so long. But I am glad that you are able to fly with your wings spread out with no limitations. He talked about access of medicines. The access to care has greatly over years improved. And we can't say we are at 100%, but I want to say that we are much better than how we were 5 years ago. And thank you so much, the management of Cancer Institute, for this effort, for continuously improving the care of our people in the country. I want also to say that we have developed the National Cancer Control Plan. And this Cancer Control Plan is detailed that if it is implemented, it will take us there. It will take us where we want to be. And I want to thank the teams that put together this control plan, and we are now ready to run with it, especially if we gain full access to work with global initiative for childhood cancer. We have seen over time improved the diagnostic and care through radiotherapy services. We have improved infrastructure, and we continue to improve. As you heard, we are expanding the access to care so that people don't travel long distances by opening up more regional centers. And we continue building capacity of our human resource, because I want to tell you that even if you have infrastructure, without a human resource, you'll be dancing in the darkness. So our priority is also continuously training and increase the oncologists and on all other support specialists to make sure that not only in the center here in Kampala, but also in the region. And this is our target, and we have already worked out a training plan in the last 10 years that will see us get quite a big number of oncologists in the country. Lastly, I wish also to take this opportunity to thank our development partners, including, among others, the International Atomic Energy Agency, Fred Hutchinson Cancer Research Center, St. Jude Children's Research Hospital, MCC Global Hope, Cambridge University, and the civil society partners, both local and international, for tremendous support towards the increasing access of care in our country. Ladies and gentlemen, we are aware that ongoing COVID pandemic has posed great challenges to meetings such as this one. But we want to thank you for braving to come to Uganda, especially those who are coming from outside Africa. I know that stories sometimes scare, but we want to thank you so much for coming, and want to appreciate those that online that made tremendous and wonderful presentations that enriched our conference. I would like to thank all delegates that traveled to come to our beautiful country, the Pearl of Africa. Enjoy the weather. I know, although we are putting AC, sometimes we don't need AC. God gave us the natural AC, where you don't need to heat the air or you don't need to cool the air. Just relax and enjoy the good weather. I conclude, let me salute visionary team behind organizing this wonderful conference. Dr. Balagade, thank you so much, and your team, an entire Cancer Institute team led by Executive Director, and the board. We want to thank you, the board, for the great work you are doing. You are making us proud. Professor Wayne, he's a modest, he stood here just, he was modest, but he's one of those people we are so proud about. And we just pray that God will continue giving you good health, that we continue receiving wisdom and counsel as we improve the care of this country. Thank you so much, and have a great day, and wish this meeting opened. Thank you very much.
Thank you very much, Dr. Diana Twine, our guest of honor, the Permanent Secretary, Ministry of Health. Doctor, before you sit, in fact, you have done your duty. We'd just like to do pictures at the front. So could I ask all the guests to stand at the front? Members of the photography team, could you kindly prepare yourselves? Because right after the pictures, then I'd like to invite you all to have lunch and also to visit. We have the Patients Pavilion, which is just outside here. What we've done for the next 2 days is that we've organized a number of powerful stories. So during the breaks and during lunchtime, pass by there, engage with some of the patients, and they'll be able to tell you how you can change their lives. I'm going to hand back over to Dr. Nixon, who's been doing an awesome job of facilitating, and he's going to continue to do that in the evening, and then I will come back later on. So, Dr. Nixon.
Thank you, Mitch. And while the pictures are being taken, I would like to make a few administrative announcements. The nutrition workshop is scheduled for Saturday at Munyonyo, and transportation will depart from here at 8 a.m. on Saturday. However, those who wish to attend the nutrition workshop should reach out to Elena via email at ejd14@cumc.columbia.edu. Please reach out to Elena today so she can organize transportation for this nutrition workshop. Secondly, these are the room allocations for the breakout sessions in the afternoon. The nurses will be in Choga Hall. That's the nursing track, will be in Choga Hall, which is upstairs. Medical 1 is also in Nile Hall, which is also upstairs. Medical 2 is in Victoria Hall, which is this hall we are seated in. And then the Civil Society track will be upstairs in the Addis Hall. Thank you. Again, those who are attending the nutrition workshop, please send an email to Elena to ensure that you're not left out. A reminder also, those who are presenting in the